The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
We will now go to nitrogen metabolism. So here we will discuss how we metabolize your amino acids. And then we will be going through heme metabolism and amino acid disorders. Okay? So you need to review the structure of your amino acids. So you see here in this diagram, you will see, okay, kailangan very familiar tayo if they ask you which amino acids have aromatic rings or have aromatic groups. So you have your phenylalanine, tyrosine, and tryptophan. Which amino acids contain aliphatic side chains? So of course, valine, leucine, isoleucine, no? So glycine, alanine. And then you need to remember some of the more trivial stuff, like what's the smallest amino acid? So glycine. Which one is an amino acid? Proline. So please go back to Dr. Rubio's lecture on that. Now, another key point you need to remember are your acidic and your basic amino acids. Your acidic amino acids are positively charged. So histidine, arginine, and lysine. You have to remember that histidine is a weak base, which is why at physiologic pH, histidine is neutral or has no charge. Whereas your negatively charged amino acids, aspartate and glutamate, are acidic. So when we discuss nitrogen metabolism, here's what you need to remember. Nitrogen intake should equal nitrogen excretion. So meaning to say, nitrogen balance is your intake minus excretion. Kung babalikan natin yung carbohydrates, how do you store excess glucose? Glycogen. Diba? How do you store excess fatty acids? Or how do you store fatty acids? As triacylglycerols. Yung mga proteins, wala yung storage form. There's no storage form for protein. Meaning to say, even if you eat a lot of protein, if you're not building new structures in the body, then you just throw them away. So that's why, kunyari sabi mo, gusto kong magkaroon ng maraming muscle, gusto kong maging maskulado. It's not enough to eat and drink protein shake every day. You actually have to exercise, because if you're not exercising, meaning to say, even if you eat a lot of proteins, those proteins will just destroy your kidneys. Okay? Those proteins will just destroy your kidneys. So nitrogen balance, very commonly asked during the board exam. When you're in a state of nitrogen balance, this means that you have more intake than excretion. So examples, adolescents, diba? With those adolescent kids, adolescent children, they're in a period of, doon sila sa growth spurt, tumatangkad sila, so they're building new structures in their body. Pregnancy is also a positive nitrogen balance. On the other hand, when you say negative nitrogen balance, there's net loss of proteins. So this happens during starvation. So when you have caloric deficit, they're not eating enough protein, so you catabolize the proteins in your body. So in kwashiorkor or marasmus. If you have severe illness like burns or severe trauma, advanced cancer, it's a catabolic state. Diba? Nawawala na, you have muscle loss. So again, if you try to think about these scenarios, why do we lose muscle mass in these scenarios? Cancer, surgery, kwashiorkor, marasmus, you are catabolizing the proteins. Why? Because you are converting proteins to glucose. Kasi nga, mas important yung glucose. Okay? So here, this shows you, if you have about 10,000 grams of functional proteins, every day you break down 400 grams. So you break down proteins two ways. You can either break them down using lysosomes or proteasomes, and you break them down into amino acids. So lysosomes degrade exogenous proteins. Endogenous proteins are degraded using proteasomes. You see this red flag? This is called ubiquitin. So kunyari ikaw protein ka, tapos dinikitan ka ni ubiquitin. Ano ibig sabihin nun? Ito na ang huling araw mo, no? Ibig sabihin, madedegrade ka na sa proteasome, ubiquitin proteasome pathway para mag-amino acids. And then every day, you also synthesize 400 grams of new proteins using translation. So ito yung i-discuss natin sa last topic, no? How you convert amino acids back to proteins. So the protein turnover is 300 to 400 grams per day. If you take in more, that's positive nitrogen balance. If you excrete more, that's negative nitrogen balance. All amino acids go to your amino acid pool. So what are the sources of amino acids? Number 1, when you break down proteins, they become amino acids. Number 2, when you take them in the diet, when you take amino acids from the diet. And then number 3, when you synthesize non-essential amino acids. So always remember, sino yung kailangan natin kunin sa diet? The essential amino acids. What are the essential amino acids? Private Tim Hall always argues, never tires. So it's always arginine, never tyrosine. Sometimes, some amino acids become essential. So for example, if you have phenylketonuria, tyrosine becomes essential. No, tyrosine becomes essential. We will explain that later. So your amino acid pool, we can get them from the diet. We can synthesize them de novo, no? We can synthesize them de novo, or we can get them from the breakdown of proteins. So ito ngayon i-discuss natin, yung catabolism. So ito, paano natin siya kinakatabolize? How do we metabolize them? Okay, so yung amino acids, paano natin sila bine-breakdown? So you see here in this diagram, no, the amino acids are broken down, and through the amino acids we produce urea, or we recycle them to become energy sources, no? Glucose, ketone bodies, lipids. So there are 2 phases. The amino acid catabolism has 2 phases. The first phase is the removal of the amino group, the alpha amino group, so to form ammonia. This is what we call the removal of the amino group is known as deamination, to form ammonia. So that ammonia can be excreted as free ammonia, but most of the time we convert that ammonia to urea. The second part, pag tinanggal na natin yung amine group, we recycle the carbon skeleton or the alpha keto acids. We convert them to either glucose or ketone bodies. So you will see here. So kunyari ito yung amino acid. Okay? This is your amino. Remember the parts of your amino acid? The alpha carbon, the carboxylic group, the amine group, and the R group. So, sino dyan ang basura? O, huwag kayong magtaas ng kamay. So, sino dyan ang basura? Ang basura ay yung amine group. So, you will see here yung ammonia, tatanggalin natin siya. So, we remove the amine. If you have an amino acid, if you remove the amine group, that amine group is converted to ammonia. Ammonia is converted to urea. Ano mangyayari dun sa natira? Pag tinanggal natin to, tatapon na lang ba natin yung natira? Ang tawag natin dyan sa natira, yung alpha keto acid. Hindi natin yan itatapon. Anong gagawin natin dyan? We will convert that either to glucose or ketone bodies. Kailan natin gagawin yon? Mamaya. No? Mamaya natin gagawin yon. Dito muna tayo sa first phase. So the first phase is the removal of ammonia to create urea. So, excess nitrogen. How do we remove excess nitrogen? So, tayo, ang tawag sa atin, ureotelic. We are called ureotelic organisms because we excrete our excess nitrogen as urea. Yung fish, some fish, Telosian fish, they excrete it as ammonia. So, ang tawag sa kanila, ammonotelic. Birds, ang tawag naman, uricotelic because they excrete it as uric acid. Okay, tayo, ureotelic. So what's the first step? The first step is transamination. So what happens in transamination? Yung mga amino acids all over the body. Okay, so imagine, yung mga amino acids all over the body, lahat sila may basurang kailangan itapon, no? So for example, this amino acid, basura niya to, yung amine group, no? So yung alpha amino group, basura yan. Anong gagawin niya? Yung alpha amino group niya, ililipat niya, itatransfer niya kay alpha ketoglutarate. See this? So, alpha ketoglutarate removes the alpha amino group. Ano mangyayari kay amino acid? Magiging alpha keto acid na lang siya. Anong gagawin natin dito? I-recycle. Kailan? Mamaya. Dito muna tayo mag-focus, no? So, saan mapupunta ngayon yung amino group? You will see the amino group is received by alpha ketoglutarate. Sa kanya mapupunta. And alpha ketoglutarate now becomes glutamate. So, si glutamate para siyang basurero. Kinokolekta niya yung basura, no? From the other amino acids. Except for lysine, threonine, proline, hydroxyproline. So, the enzyme that does this, that performs this transfer is called an aminotransferase. So, ang tawag sa kanila, aminotransferases. And they require the vitamin B6 pyridoxal phosphate. Again, yung amino acids, except for lysine, threonine, proline, hydroxyproline, ang ginagawa nila, they will transfer their amino groups to alpha ketoglutarate. Alpha ketoglutarate will become glutamate. Yung amino acid, pag tinanggalan mo ng ammonia, magiging alpha keto acid. Anong gagawin natin doon? I-recycle. So you will see now, glutamate has the ammonia. There are two aminotransferases that you need to remember. First is alanine aminotransferase. So here, you need to pay attention nasan yung ammonia. Alanine aminotransferase, yung ammonia ni alanine, ililipat niya. So you will see si alanine, if we remove ammonia, ano mangyayari sa kanya? Alanine becomes pyruvate. That's why we say the alpha keto acid of alanine is pyruvate. Alternatively, you can say the carbon skeleton of alanine is pyruvate. Pero the reverse reaction can also happen. Pyruvate, we can add ammonia and it becomes alanine. Okay? How about here? Aspartate aminotransferase naman. Aspartate aminotransferase, look here. Oxaloacetate. Oxaloacetate from Krebs cycle. If we add ammonia, it becomes aspartate. Conversely, aspartate, if we remove ammonia, it becomes oxaloacetate. So, tatandaan nyo itong dalawang to. No? So, si alanine aminotransferase, no, ang ka-exchange na din, si alpha ketoglutarate. To, sabi natin, di ba? Look, si alanine, pag nilipat niya yung ammonia niya kay alpha ketoglutarate, si alpha ketoglutarate magiging glutamate. Is that clear? So, the enzyme that does this is ALT, alanine aminotransferase. No? Ito yung ngayon yung, ito yung ano nyo, no? ALT. No? ALT. However, ito naman sa kabila, ganun din. Si aspartate, pag binigay niya yung ammonia niya kay alpha ketoglutarate, si alpha ketoglutarate magiging glutamate, si aspartate magiging oxaloacetate. So, ito naman yung AST. So, these enzymes are reversible. So, si alanine aminotransferase, ano yung mas common? Yung pababa. No? Ang mas common yung pababa. No? Yung alanine magiging pyruvate. Dito, ang mas common, yung oxaloacetate maging aspartate, yung pababa. Okay? Mas common yung reverse reaction, yung si glutamate yung magpapasa papunta kay aspartate. So, bakit kaya gano'n? Bakit kaya natin nililipat lahat kay glutamate yung ammonia? No? Bakit lahat na lang kay glutamate? No? So, from alpha ketoglutarate magiging glutamate. Kasi si glutamate siya yung ultimate basurero. What will happen now to glutamate? So, after collecting all the ammonia, glutamate will go to the liver or the kidney. So, si glutamate, you will see, dala-dala niya yung basura. It will travel to the liver or to the kidney. And in the liver, what will happen? Glutamate will be deaminated. So, it will release the ammonia using glutamate dehydrogenase. So, si glutamate, tinanggalan mo ng ammonia, magiging alpha ketoglutarate na ulit. Ano mangyayari ngayon sa ammonia? Yung ammonia na yan, i-release niya sa liver. I-release niya sa kidney. And then, no? Pwede ngayon siyang i-excrete. So, that ammonia. So, again, look. First step, the amino acids will transfer their ammonia to glutamate. Okay? Glutamate, so that's transamination, which requires pyridoxal phosphate. Glutamate will travel to the liver. In the liver, glutamate will be deaminated para ma-release yung ammonia. No? At yung ammonia in the liver will be converted to urea. So, yun na ngayon yung urea cycle. Okay, so kaya ultimate basurero si glutamate. Kinokolekta niya yung mga ammonia para madala niya sa liver. In the liver, it will undergo deamination. So yung ammonia marirelease, alpha ketoglutarate na ulit siya. Pwede na naman siyang mag-collect ng basura. Babalik na naman siya sa glutamate. Pupunta na naman sa liver to release ammonia. ammonia will be converted to urea. So remember that, the role of glutamate. It collects the alpha amino group from other amino acids and transports the ammonia to the liver, where the ammonia is released via oxidative deamination, and ammonia is converted to urea. There are two other amino acids that are important in the transport of ammonia, or nitrogen metabolism. Number one is glutamine. So ano naman yung glutamine? In peripheral tissues, sometimes you have excess ammonia. Okay? So in peripheral tissues, you have excess ammonia. That excess ammonia can still combine with glutamate. So glutamate, basura, may hawak na siyang basura, dadagdagan mo pa siya ng basura. So look, glutamate can accept the ammonia group and it becomes glutamine. The enzyme is glutamine synthetase. And then this glutamine can go to the liver or the kidney. In the liver, especially when you have high protein intake, yung glutamine, we can release the ammonia. So glutamine minus ammonia, glutamate. Bawasan mo pa ng isa mong ammonia, alpha ketoglutarate. Okay? And that ammonia will now go to urea synthesis. How about in the kidneys? Glutamine, you bring the glutamine to the kidney. In the kidney, you also have glutaminase. Glutaminase will release the ammonia, and that ammonia is excreted in the urine. When do you do that? During metabolic acidosis. If you have metabolic acidosis, you need to excrete the protons. And glutamine helps you excrete these excess protons. Again, saan important si glutamine? Peripheral tissues. It's important in the transport of excess ammonia in peripheral tissues. How about alanine? Alanine is important in muscle. So in muscle, if you have excess ammonia, look here. If you have excess ammonia, that ammonia from amino acids is added to pyruvate. Remember, ammonia plus pyruvate, amino group plus pyruvate becomes alanine. Alanine will now travel to the liver. And in the liver, that alanine is deaminated. How do we remove the amino group from alanine? Anong enzyme? ALT, alanine aminotransferase. Kaya nga kasama yung ALT sa liver, no? Sa liver function tests. So alanine, if you remove the ammonia, it becomes pyruvate again. Pyruvate can be converted to glucose using what pathway? Gluconeogenesis. And glucose can travel in the blood back to glucose. Glucose will be metabolized to pyruvate using what pathway? Glycolysis. The pyruvate can accept ammonia and it becomes alanine. So, paikot-ikot lang. This is your glucose-alanine cycle. Analogous to your Cori cycle. So, once again, para lang hindi malito, yung ammonia, basura. Kailangan nating itapon. Saan natin yan pwedeng itapon? No? Dadali natin yan dapat sa liver para maging urea, or excess ammonia can be excreted in the kidneys when you have metabolic acidosis. Sino yung tatlong amino acids na kailangan yung tandaan? Glutamate. Glutamate transports the ammonia from the other amino acids. Glutamine transports ammonia from the peripheral tissues. Alanine transports the ammonia from muscle. Remember the alpha keto acid pairings. Okay? Alpha ketoglutarate. If you add ammonia, it becomes glutamate. Oxaloacetate. If you add ammonia, it becomes aspartate. Okay? Glutamate. If you add another ammonia, it becomes glutamine. And then pyruvate. If you add ammonia, it becomes alanine. So we now go to the urea cycle. So what is it for? No? So the urea cycle converts the body's nitrogenous waste to urea. So in simple terms, no? So sa urea cycle, gumagawa tayo ng urea. Ano yung ingredient natin for urea? So, nanggagaling siya from ammonia. So remember, kanina yung basura dinala natin sa liver. So this happens in the liver. Yung mga ammonia na dinala natin sa liver, i-convert natin siya to urea. Okay? So why do we need to do that? Bakit hindi lang tayo umihi ng ammonia? No? Ba't hindi lang tayo mag-excrete ng ammonia? Ba't kailangan pa i-convert sa urea? Because urea is more water-soluble and it is less toxic than ammonia. Mas gusto natin yun, no? Kaysa ammonia yung iniihi natin. Where does it happen? Again, only in the liver. That's why if you have liver damage, kunyari end-stage liver disease, like when you have cancer, hepatocellular carcinoma, or severe cirrhosis, then, ano mangyari? Tataas yung ammonia. Kasi hindi natin siya ma-convert to urea. Ayaw natin yon because elevated ammonia levels is bad for your body. Where does it occur in the liver? Both cytosol and mitochondria. So if you remember, what's the mnemonic for pathways that occur in both cytosol and mitochondria? HUG, heme synthesis, urea cycle, and gluconeogenesis. The substrates are ammonia, aspartate, and carbon dioxide. Remember these three, ammonia, aspartate, and carbon dioxide. And this is activated. Kailan tayo mag-activate ng urea cycle? The most important activator of the urea cycle is N-acetylglutamate. So pag maraming basurero, N-acetylglutamate, maraming basura. Kailangan yung basura i-convert natin to urea. Okay, so after a protein-rich meal, yung acetyl-CoA nagko-combine yan with glutamate to form N-acetylglutamate. And that drives urea cycle. The product, as I've said, is urea. The rate-limiting step is the conversion of ammonia and carbon dioxide to carbamoyl phosphate, catalyzed by carbamoyl phosphate synthetase 1. As I've said, the activator is N-acetylglutamate. This is the molecule urea. Kailangan kabisado nyo to. So you will see, it has 1 carbon, 2 nitrogens, and 1 oxygen. So yung dalawang nitrogen, you will see, 1 nitrogen will come from aspartate. Another nitrogen comes from ammonia. No? Yung carbon tsaka oxygen, galing yan sa carbon dioxide, shown here are bicarbonate. So wais yung body natin, di ba? Magtatapon ka na lang din ng basura, which is ammonia, sabayan mo na ng isa pang basura, which is carbon dioxide. So that's why, take note, urea, okay? The immediate precursors are carbon dioxide, ammonia, and aspartate. But let's backtrack. Sino ba nagdala ng ammonia sa liver? Sino yung basurero? Si glutamate. No? Si aspartate, saan ba nanggaling yung ammonia ni aspartate? Kay glutamate din yan. If you remember, aspartate aminotransferase transfers ammonia from glutamate to aspartate. Kaya sa totoo lang, yung dalawang nitrogen na to, kay glutamate yan nanggaling. No? Kay glutamate yan nanggaling. Pero, ang nag-shoot lang, si ammonia at si aspartate. Pero sa kanya nanggaling yan. So, look here, no? And what do I mean? So, look. Okay, yung ammonia, yung color blue, galing yun kay glutamate. Diba? If you remember, the amino acids, they will pass the ammonia to glutamate. So, using aminotransferases. And then glutamate will travel to the liver. This is the liver. Glutamate travel to the liver where it is deaminated using glutamate dehydrogenase, releasing ammonia. Sa peripheral tissues, glutamine, yung glutamine, pupunta yan sa liver. It can be deaminated to form glutamate. And then glutamate deaminated further to release ammonia. Si muscle, may ammonia sila. Yung ammonia, bibigay niya kay pyruvate para maging alanine. Alanine will travel in the liver where you have alanine aminotransferase, malipat kay glutamate. Glutamate i-release yung ammonia, ammonia na naman. Okay, so lahat ng ammonia, kanino nanggagaling? Kay glutamate. How about here? Si oxaloacetate, remember? Sabi natin, no? Si oxaloacetate, pag binigay sa kanya ni glutamate yung ammonia, magiging aspartate. Kaya ito, yung ammonia na to, utang din niya yan kay glutamate. Eh, tatandaan niyo yan. So even though it is ammonia and oxaloacetate, ammonia and aspartate that are the direct donors of ammonia, these nitrogens actually come from glutamate. This is the urea cycle. This is a lot more difficult to memorize than your Krebs cycle, but I hope to show you it's actually quite straightforward. So remember that the pathway happens in both mitochondria and cytosol. Saan mauuna? Sa mitochondria. Ito pa yung tatandaan. Yung pathways that happen in both, all of them happen in the mitochondria first. So in the case of the urea cycle, look here. The rate-limiting step is the conversion of carbon dioxide, you combine carbon dioxide and ammonia to synthesize carbamyl phosphate. So carbon dioxide plus ammonia, carbamyl phosphate. This happens in the mitochondria. Si carbamyl phosphate, sasalubungin siya ni ornithine. Okay? Sasalubungin siya ni ornithine to form citrulline. And then citrulline will go out. So tandaan nyo to, si citrulline siya yung lalabas papuntang cytosol. And then si citrulline, dadagdagan natin ng aspartate to form arginosuccinate. Lalabas ngayon si fumarate to form arginine. And then we add water to generate urea. Meron na naman tayong ornithine ulit. So you will see that's how you form urea. No? That's how you form urea. The enzymes, these are the enzymes. So COAAA. So carbamyl phosphate synthetase 1 because you have CPS2. Yung CPS2 nasa pyrimidine synthesis. Papakita natin later. Number 2, ornithine transcarbamylase. And then yung mga nasa cytosol, puro letter A. Paiksi ng paiksi. Arginosuccinate synthetase, arginosuccinate lyase, arginase. So take note, there are 5 enzymes. The most common enzyme deficiency is this one, ornithine transcarbamylase. The rate-limiting step is carbamyl phosphate synthetase 2 and it is activated by N-acetylglutamate. So pag maraming basura, maraming acetylglutamate, kailangan nating i-activate yung Krebs cycle. Kasi kailangan nating mag-convert ng ammonia to urea. Okay? Huwag niyong kakalimutan. So, let me ask you this. So, if they ask you what are the ingredients of urea, so carbon dioxide, aspartate, ammonia. But the amino groups of aspartate and the free ammonia, they both come from glutamate. How many ATPs are needed to create one molecule of urea? If you look at the diagram, you will see 2 ATPs here and 1 ATP here. But the answer is not 3. The answer is 4. Bakit 4? No? Bakit 4? Because look, here in the first step, carbamyl phosphate synthetase. No? Carbamyl phosphate synthetase 1, 2 ATPs are needed. And then step number 3, arginosuccinate synthetase. Even though you only use 1 ATP, yung ATP naging monophosphate. So, 2 ATPs yung equivalent nun. Kaya the correct answer is, to create 1 molecule of urea, you need 4 ATPs. Okay, so wag kakalimutan, no? So, 4 high energy bonds ang equivalent. So, things you need to remember. Okay, to synthesize 1 molecule of urea, 1 mole of urea, you need 3 moles of ATP, but 4 high energy bonds, so 4 ATP equivalents. The most important activator is N-acetylglutamate. Okay, so kailan tataas yung urea cycle? Low protein diet or high protein diet? Siyempre, high protein diet, di ba? Pag marami kang protein sa kinain, mas maraming basurang kailangang itapon. So, ammonia to urea. Pag may problem sa urea cycle, ano mangyayari? Ammonia will go up. Urea will go down. No? So, tataas yung ammonia levels natin. Ayaw natin yun. No? Kasi nga, kung may problem tayo sa urea cycle, hindi natin ma-convert yung ammonia to urea. And you only have the liver to produce urea. That urea, where will it go? It will travel in the blood to the kidneys so that it can be excreted in the urine. However, some of it can go to the intestines. And in the intestines, you have urease-containing bacteria. So yung urea, binabalik nila to carbon dioxide and ammonia. No? Kainis. No? After mo paghirapan, babalik lang nila doon. So this becomes important in hyperammonemias. So why is hyperammonemia dangerous to us, to human beings? Pag mataas kasi yung ammonia levels, no? Ammonia can be directly toxic to the central nervous system. No, nervous system yung kawawa dito. No? So that's why you see clinical presentation, tremor, slurring of speech, vomiting, blurring of vision. Ang tawag dito sa tremor na to? Flapping tremor, asterixis. No? Asterixis. Ano bang nangyayari dyan? Bakit nervous system yung kawawa? Pag mataas ang ammonia, anong gagawin ng ammonia? Si ammonia, kakabit siya kay alpha-ketoglutarate. Saan ba nanggagaling si alpha-ketoglutarate? Sa Krebs cycle. So yung Krebs cycle, mauubusan ng alpha-ketoglutarate kasi lahat sila magiging glutamate. So imagine mo, no, yung brain na de-deplete ng acetyl-CoA. Si alpha-ketoglutarate magiging glutamate. And what is the role of glutamate in the central nervous system? It is excitatory. So pag sobra-sobra yung excitatory neurotransmitter sa central nervous system, you have excitotoxicity. At the same time, that glutamate, tatanggap pa siya ng ammonia para maging glutamine. The problem is glutamine can be directly toxic to the neurons and the glial cells, yung supporting cells. So papatayin niya yung mga neurons at glial cells. So that's why you have cerebral edema, coma, and death if it's not addressed. So first is hereditary hyperammonemia. Pag sinabi natin na hereditary hyperammonemia, merong enzyme deficiency. No? There's enzyme deficiency in the urea cycle. Tataas ngayon yung ammonia natin. So, remember this. The most common is deficiency of enzyme number 2, ornithine transcarbamylase. But the most severe will be deficiency of enzyme number 1, carbamoyl phosphate synthetase 1. So all of the hyperammonemias, hereditary hyperammonemias, they will lead to mental retardation, no? Tapos ito pa yon. Paano natin sila madidistinguish sa isa't isa? So actually, lahat kasi sila hyperammonemia, no? Lahat sila will present with elevated ammonia. So the only way to distinguish them is to measure the metabolites, no? So for example, no, when you look at this table, you will see lahat sila hyperammonemia. But depending on the enzyme, mag-iiba yung accumulating metabolite. Why? So for example, sige nga, kapag may block kay ornithine transcarbamylase, wala to. Diba? Si ornithine transcarbamylase. Ano ngayon na mag-accumulate? Okay? So tataas si carbamoyl phosphate. Kasi hindi siya makamove forward. No? So tataas si carbamoyl phosphate. That carbamoyl phosphate will be diverted to pyrimidine synthesis. Sa pyrimidine synthesis, magsisynthesize tayo ng maraming pyrimidines, leading to elevated levels of ammonia and orotic acid. In contrast, kapag ang block natin carbamoyl phosphate synthetase 1, anong tataas? Ammonia lang. No? Ammonia will be high. Hindi tayo makakasynthesize ng citrulline. No? Hindi tayo makasynthesize ng carbamoyl phosphate. Ammonia lang yung tataas. So yung type 1, yun yung pinaka-severe. No? Talagang first few days of life, they will have hyperammonemia. And if we don't recognize this, they will die. Ito, tingnan natin. No? Paano naman kung ang wala, arginine-succinate lyase? Ano kaya yung tataas? So kung may block dito, tataas yung arginine-succinate. So look here, arginine-succinate lyase deficiency. No? You will have elevated arginine-succinate. So lahat sila, tinan mo, hyperammonemia. No? Kaya para sagutin to, no, when you are given cases like this, no, usually bibigay na case dyan, infant, first few days of life, failure to thrive, hyperammonemia. Hahanapin nyo, ano yung tumaas? Pag sinabi ang tumaas citrulline, ano kaya enzyme deficiency? Arginine-succinate synthetase. Kasi tataas to, ibig sabihin hindi siya makamove forward doon. Okay, so treatment will be, no, so ang treatment sa mga to, we have to restrict dietary protein. Okay, we have to restrict dietary protein. Kasi nga, tataas yung ammonia levels nila. You can also give phenylbutyrate, which is converted to phenyl acetate, binding to glutamine. No? So, kasi si glutamine, ayaw natin. No? Toxic yan sa body, sa brain. Compared with your hereditary hyperammonemia, ano naman yung acquired hyperammonemia? Yung acquired hyperammonemia, nangyayari ito dun sa mga may liver failure. No? So, cirrhosis, hepatocellular carcinoma. So, ang mangyayari, no, yung portal blood, because of portal hypertension, yung intestinal blood, hindi na siya makapunta sa portal vein. Pupunta siya ngayon sa systemic circulation, bypassing the liver. So, yung ammonia, hindi natin matidetoxify. So, you will see here, no? So, elevated ammonia. Okay, so when you get protein, digest proteins, they will when you digest proteins, so kumain ka ng protein, mako-convert sila to ammonia because of your bacterial urease. That ammonia cannot go back to the liver kasi nga may portal hypertension. Diretso na siya sa systemic circulation. Pag mataas yung ammonia levels, tataas ang glutamine. Kasi tataas ang glutamate, tataas ang glutamine. Glutamine is toxic to neurons and glial cells. Okay? So, yan yung hepatic encephalopathy. Once again, you will discuss this in detail in internal medicine, ng management of hepatic encephalopathy. So just review the guidelines, no, how we treat them. So yung protein restriction, or we give them laxatives para mabilis yung transit, etc. sa GI tract. Okay, so let's go back. So, ibig sabihin, sabi natin, no, amino acid, anong ginawa na natin? First phase, we remove the ammonia and the ammonia is converted to urea. Pag tinanggalan natin ng ammonia yung uric acid, pag tinanggalan natin ng ammonia yung amino acid, what do we get? Your alpha keto acid. Or review, alanine, if you remove ammonia, what do you get? Pyruvate. Glutamate, if you remove ammonia, what do you get? Alpha ketoglutarate. Aspartate, if you remove ammonia, oxaloacetate. Glutamine, if you remove ammonia, glutamate. No? Kasi glutamate, tatanggalan mo na naman ng ammonia para maging alpha ketoglutarate. So, anong gagawin natin sa alpha keto acids na to? Tatapon ba natin sila? I-recycle. Kailan natin i-recycle? Ngayon na yon, hindi na mamaya. No? So, now, we will discuss how do we metabolize these alpha keto acids. So, when you look at this diagram, you will see the alpha keto acids of the different amino acids. Pwede silang pumasok sa Krebs cycle or sa glycolysis. Okay? They can enter the Krebs cycle or glycolysis or ketolysis. So, you will see yung mga color blue, pwede silang maging acetyl-CoA or acetoacetyl-CoA. Can acetyl-CoA become glucose? No. Once you convert pyruvate to acetyl-CoA, there is no turning back. So, yung mga nagiging acetyl-CoA, hindi na sila pwedeng maging glucose. Pero pwede silang maging ketone bodies. O, review. From acetyl-CoA, how do we create ketone bodies? Ano yung rate-limiting step? HMG-CoA synthase. And what are the ketone bodies that you produce? Acetoacetate, beta-hydroxybutyrate, and the useless metabolite, acetone. Okay? So, itong mga amino acids na blue, pwede sila maging ketone bodies. So, yung mga amino acids naman na pink, dahil pwede silang pumasok sa Krebs cycle or sa glycolysis, pwede silang maging glucose. Okay, so let's take a look. So for example, when you look at proline, proline can be converted to glutamate, can be converted to alpha ketoglutarate. So papasok siya sa Krebs cycle. So how will we classify proline? Proline is called glucogenic because it can be converted to glucose. How about if we look at lysine, no? If you look at lysine, no? So you look at lysine, lysine can only become acetyl-CoA. Because it can only become acetyl-CoA, it cannot enter the Krebs cycle, pwede lang siya maging ketone bodies, no? Pwede lang siya maging ketone bodies. That's why lysine is called purely ketogenic. Now, let's compare that with phenylalanine. Phenylalanine here can be converted to acetyl-CoA. That's why it is ketogenic. At the same time, it can be converted to fumarate. Diba? It can be converted to fumarate, which can enter the Krebs cycle. No? Which can enter the Krebs cycle. And therefore, okay, it is also glucogenic. Kaya ang classification ni phenylalanine, both glucogenic and ketogenic. Okay, both ketogenic and glucogenic. O, kung babalikan nyo yung Krebs cycle, sino dyan yung nakita nyo din sa urea cycle? Si fumarate, di ba? So, that's why, no? So, kung babalikan nyo yung urea cycle natin dito, no? So, let me see. If we go back to urea cycle, fumarate's there. Fumarate serves as the link, no? Serves as a link between the Krebs cycle. Serves as a link between the Krebs cycle and the urea cycle. So, mahirap makabisado to, yung mga entry points na yan. Siguro, very, very rarely, maybe once every 10 years, tatanong nila yan. Pero ito, definitely, kailangan nyo itong kabisaduhin, itong table na to. Okay? So, just remember, there are two purely ketogenic amino acids. Yung dalawang letter L, lysine and leucine. There are four that are both ketogenic and glucogenic. So, phenylalanine, tyrosine, isoleucine, and tryptophan. Sometimes, some textbooks will include threonine. No? That's why you will see in some textbooks, threonine is also considered both. And then everything else will be purely glucogenic. So, kabisaduhin nyo lang to. Itong anim na to. Everything else will be purely glucogenic. So, for example, paano sila magtanong? How would you classify proline? No? Purely ketogenic, purely glucogenic, or both? Diba? The answer is purely glucogenic. Or pwede naman baliktarin nila yung tanong, no? Which of the following is purely ketogenic? Hanapin mo yung lysine or leucine sa choices. So, pwedeng ganun kadali yung question, no? Synthesis of non-essential amino acids. Sabi natin, no, the non-essential amino acids, yung hindi private team hall, always argues, never tires, pwede natin silang masynthesize in the body. So, kailangan more or less kabitado nyo itong mga to. Saan sila nanggaling? Sino yung mga madaling ma-memorize? Si tyrosine. Remember that tyrosine comes from phenylalanine. So, phenylalanine, you add the hydroxyl group, phenylalanine hydroxylase, it becomes tyrosine. O, si aspartate, saan nanggagaling si aspartate? Transamination of oxaloacetate. And then, if you add ammonia to aspartate, it becomes asparagine. O, si glutamate, saan nanggagaling? Transamination of alpha-ketoglutarate. You add another ammonia, you form glutamine. So, minsan tinatanong nila, no? So, kunyari, sasabihin nila, so proline comes from which amino acid? Glutamate. O, ito pa isang important matandaan, no? Methionine. Methionine is used for the synthesis of cysteine. No? So, methionine is used for the synthesis of cysteine, and this will become important later in homocystinuria. Okay, so, yun yung mga most essential, no? So, in summary, so amino acid catabolism consists of two phases. First, you need to deaminate, okay, and then you form ammonia. And then second, you convert the carbon skeleton to glucose, ketone bodies, or both. So remember the three amino acids that have important roles. Ang ultimate basurero, si glutamate. So we'll get ammonia from the other amino acids. Glutamine retrieves ammonia from peripheral tissues. Alanine is important for transport of ammonia from muscle. Remember, the alpha-keto acids, they can be converted to ketone bodies, glucose, or both. So you classify them as purely ketogenic, purely glucogenic, or both. No? Just memorize which one is which. The urea cycle in the liver is essential to convert the body's nitrogenous waste, ammonia, to urea. So remember the rate-limiting step, carbamoyl phosphate synthetase 1. Remember the precursors of urea? Ammonia, aspartate, and carbon dioxide. But both nitrogens come from glutamate. If you have a problem in the urea cycle, then it presents with hyperammonemia. All of them will present with elevated ammonia levels. So how will you differentiate them? Look at the other metabolites that are accumulating. Depending on the metabolite that's accumulating, then you will be able to diagnose the enzyme deficiency. How else do we use amino acids in the body? No? So that will be what we'll discuss for this next part, which is amino acid metabolism. So this table is very important. No? I cannot emphasize this enough. Ito yung isa sa mga table na marami usually lumalabas. No? Lalo na minsan, sometimes 3 questions, no? Galing lang sa table na to. And actually, you should already be familiar with this table because you also already discussed this briefly with Dr. Rubio. So this shows you what are the specialized products from your amino acids. So if I ask you, where do we get histamine? It comes from histidine. No? So what reaction? Histidine decarboxylase. No? So it's a decarboxylation reaction. Histidine is converted to histamine. Similarly, glutamate. How do we convert glutamate to GABA? That's also a decarboxylation reaction. No? So glutamate to GABA, that's a decarboxylation reaction. Where do we get tyrosine? Tyrosine, we get it from phenylalanine. No? Where do we get creatinine? Creatinine comes from arginine. Where do we get bile acids? Bile acids. Sorry, not where do we get bile acids. What's conjugated to bile acids? No? So, what amino acid is added to bile acids to make them more polar? The answer is glycine. So, as you can see, no, very important to, no? So, very important. Huwag niyong kakalimutan, no? Kasi lagi itong tinatanong. No? Lagi itong tinatanong. So, what is S-adenosylmethionine? So S-adenosylmethionine, this is synthesized from methionine, obviously, and ATP. So S-adenosylmethionine is important because it is the source of methyl groups. So pag kailangan nating mag-add ng methyl groups, like for example, conversion of norepinephrine to epinephrine, acetylserotonin to melatonin, no? Kailangan natin ng methyl group na yun. Ang magpo-provide ng methyl group is S-adenosylmethionine. Yung S-adenosylmethionine naman, once you remove the methyl group, it becomes S-adenosyl homocysteine. Now, you must remember this. No? So, you will see here, okay? So, S-adenosylmethionine. So, yung methyl transferase reaction. So, you will see this, no? Yung X, kakabitan natin ng methyl group. So, yung kunyari, norepinephrine. Gagawin nating epinephrine. So, nanggagaling yung methyl group niya kay S-adenosylmethionine, which then becomes S-adenosyl homocysteine. And the other thing you need to remember, look here, methionine. Methionine is used to produce cysteine. So this is important. Methionine is converted to homocysteine using B12, and then homocysteine converted to cystathionine and cysteine using B6. So babalikan natin to later sa homocysteinuria. No? Then here, folate. Folate, 5-methyl tetrahydrofolate is useless. We need to convert it to tetrahydrofolate and you need B12. So kung wala tayong B12, hindi natin ito mako-convert to tetrahydrofolate. Useless yung folate natin. No? Useless yung folate natin. Catecholamine metabolism. What are your catecholamines? Where do we get your catecholamines? Dopamine or epinephrine and epinephrine? True love does not exist. Galing sila kay tyrosine. So, you need to memorize this, unfortunately, kasi tinatanong nila to. So, review that tyrosine comes from phenylalanine. Then, from tyrosine, it is converted to DOPA using tyrosine hydroxylase. So, tandaan nyo, ano? Tyrosinase converts tyrosine to melanin. Pero pag catecholamine pathway, tyrosine hydroxylase. DOPA is converted to dopamine using DOPA decarboxylase. So, ang kailangan naman na vitamin ito, vitamin B6, pyridoxal phosphate. From dopamine, you convert it to norepinephrine using dopamine hydroxylase. Ang kailangan naman ito, vitamin C. So, take note, catecholamine metabolism, you need 2 vitamins. Vitamin B6 to convert DOPA to dopamine. Dopamine to norepinephrine requires vitamin C. And then norepi, converted to epi, no, using phenylmethanolamine methyltransferase. Saan manggagaling yung methyl group? Sabi natin kanina, S-adenosylmethionine. Remember, no, the methyl group will come from S-adenosylmethionine. Ang end product nito, no, ang end product, you will have your catecholamines. Now, take note, your catecholamines are inactivated by monoamine oxidase and by catechol O-methyl transferase. So, yung norepi and epi, they are converted to vanillyl mandelic acid, VMA. So, kaya pag meron tayong pheochromocytoma, tumataas yung VMA, urinary VMA. No? So, yun yung mini-measure natin. Phenylketonuria, as I've said, phenylalanine converted to tyrosine using phenylalanine hydroxylase. So, kung walang phenylalanine hydroxylase, tataas si phenylalanine, bababa si tyrosine. Phenylalanine is converted to toxic metabolites, while tyrosine becomes essential in the body. So, kapag walang enzyme, phenylketonuria. Pero remember, yung enzymes kailangan ng cofactor. This time, tetrahydrobiopterin. Pag walang tetrahydrobiopterin, anong sasabihin ni phenylalanine hydroxylase? Ayoko nga. So, if you are deficient in tetrahydrobiopterin, phenylketonuria pa din yon. So, the phenylketones will accumulate. So, ano nangyayari? So, dahil walang enzyme, look, phenylalanine will be converted to phenylpyruvate, phenylactate, phenylacetate. These are toxic to the body. Okay? Tyrosine becomes essential. Hindi tayo makaproduce ng tyrosine. Presentation. Bakit nagkakaroon tayo ng severe mental retardation? Diba? Kung wala kang catecholamines, wala tayong neurotransmitters. Bakit tayo nagkaka-fair skin? Kasi wala tayong melanin. No? Wala tayong melanin. Musty body odor because of the phenylketones. Treatment consists of tatanggalin natin si phenylalanine. Tapos magsusupplement tayo ng tyrosine. So ito, take note ha. In studying the amino acid disorders, most of the time, the treatment is dietary restriction, bawas ng proteins. So, tinatanong nila minsan anong pwedeng kainin, anong bawal kainin. So, please try to become familiar with this. So, remember that, hindi lang proteins yung bawal, no? Pati yung starches, including bread, potatoes, corn, beans, no? Nire-restrict din. So, ito naman yung pwede, low protein food. Okay? So, remember, kaya pag hindi natin ginawa to, this can be fatal to the child. Alkaptonuria. Sa alkaptonuria, ang amino acid involved, tyrosine pa din. No? So, look here. This is a deficiency in the tyrosine pathway wherein yung homogentisate, kino-convert dapat siya to mallyl acetoacetic acid using homogentisate oxidase. Pag walang homogentisate oxidase, tataas yung homogentisic acid. Homogentisic acid is an okay? So, alkapton body yan. Kaya siya alkaptonuria. Tataas yung homogentisate, which is an alkapton body. Ito yung mangyayari. Urine turns black on standing. No, hindi ibig sabihin ng pag umihi ka na nakatayo, itim yung ihi mo. No? Pag umihi ka like this, tapos you let it stand, hayaan mo siyang nakatiwangwang, mag-change siya in color. No? So after 24 hours of exposure to the environment, you will see there's a change in color in the urine. Ano ngayon? No? This can actually be, yun lang, pwedeng very benign symptom, but unfortunately, you can have deposition of pigments in connective tissue. So, for example, ang tawag doon, ochronosis. No? You can also have debilitating arthralgias. So, this is pigmentation of the sclera, no? Because of, and pigmentation of the ear cartilage, alkaptonuria. So, the treatment, you want to reduce pigment deposition, no? So, you want to reduce pigment deposition. How can you do this? You give vitamin C. So, vitamin C, it's a mild antioxidant, helps reduce the conversion of homogentisic acid to the deposit that builds up in cartilaginous tissues. Of course, you reduce phenylalanine and tyrosine. So, hindi lang phenylalanine yung bawal, pati yung tyrosine babawasan mo na din. Albinism. The problem with albinism, no, walang melanin. And remember, ang melanin, tyrosinase. No? Tyrosine hydroxylase, catecholamine, tyrosinase, melanin yan. So, clinical presentation, they will have absence of pigment from hair, eyes, and skin. Ang problem doon, no, they are at risk of cancer. So, look this, pink eyes. So, true albinos have pink eyes, they have fair skin. Tyrosinemia. So, tyrosinemia, you have elevated levels of tyrosine. So, you can have type 1 or type 2. Okay, so, type 1 is defect in fumarate acetoacetate hydroxylase. Type 2, tyrosine aminotransferase. I don't think they've asked this in the board exam. I'm only including this because this is in Harper. Ito yung mas important. Homocystinuria. Babalikan natin si homocystinuria. Di ba binanggit ko to kanina? Homocysteine. So, yung very analogous to sa phenylketonuria. So, yung methionine, anong sabi natin? Methionine can be converted to homocysteine. And then homocysteine is converted to cystathionine and then cysteine. The enzyme here is cystathionine synthase, which requires vitamin B6. So, the problem with homocystinuria is you do not have cystathionine synthase. So, cystathionine synthase is deficient. Ano kaya mangyayari? Methionine levels will go up, cysteine levels will go down. Now, homocysteine, you can actually convert it back to methionine using methionine synthase. Ang kailangan naman ito, vitamin B12. So, the problem is, no, you will have high levels of homocysteine and methionine. Ayaw natin kay homocysteine. Why? Because homocysteine, anong nangyayari? Yung blood ng patient nagiging prone to formation of thrombi. Nagiging mas malapot. No? Think of it that way. Mas malapot yung blood nila. So they're prone to myocardial infarction, stroke in young patients. So that's why homocystinuria is a differential when you have stroke in the young. There's lens displacement which is downward. Okay, saan nyo pa narinig yung lens displacement? Marfan. Remember, Marfan, upward. Homocystinuria, downward. Okay? So, homocystinuria, downward lens displacement. Marfan syndrome, upward. So, treatment. So, dahil ang ayaw natin, methionine, you avoid methionine in the diet. Okay? You supplement with vitamin B6. So usually yung mga patients, so sabi natin, di ba, vitamin B6 lowers homocysteine levels. Yung mga patient na responsive sa vitamin B6, usually they will have a milder and later onset of clinical symptoms. Yung homocystinuria, iba sa cystinuria. Pag sinabi naman natin na cystinuria, there's a problem with the reabsorption of cysteine, ornithine, lysine, and arginine. So these patients, they cannot reabsorb cysteine, ornithine, lysine, and arginine. So ano ngayon na mangyayari? Yung cola, hindi nila ma-reabsorb. So ano nangyayari? Nagbi-build up yan as kidney stones. So you'll have excess levels of cysteine in the urine, leading to staghorn calculi. So treatment, no, the urine kasi becomes acidic. So we treat this by alkalinizing the urine, acetazolamide. So tandaan, cola, umiihi ka ng Coca-Cola, no? Cystinuria, umiihi ka ng Coca-Cola, you get stone formation. Methylmalonic acidemia. So, ito naman, yung methylmalonic acidemia, similar sa homocystinuria in that you also have, the patient is also prone, no? Patient is also prone to stroke. And, right? So, patient is also prone to stroke because of accumulation of methylmalonic acid. So, saan yun narinig yung methylmalonic acid? Binanggit na natin to kanina. So, methylmalonyl-CoA is part of the metabolism of propionyl-CoA. Saan tayo nakakakuha ng propionyl-CoA? Fatty acids with an odd number of carbons. So, remember, propionyl-CoA is converted to methylmalonyl-CoA, and then methylmalonyl-CoA is converted to succinyl-CoA using methylmalonyl-CoA mutase. So, methylmalonyl-CoA mutase requires vitamin B12. Pag wala tayo nitong enzyme na to, methylmalonyl-CoA mutase, tataas si methylmalonic acid. Bakit siya naging important sa proteins, di ba? Because yung isoleucine, yung valine, yung threonine, and methionine. So remember these four. MVIT, parang multivitamins. Methionine, valine, isoleucine, and threonine. Dito sila pumapasok sa pathway na to. No? Dumadaan sila. Yung metabolism nila dadaan kay methylmalonyl-CoA. Kaya kung wala ito, tapos kumain ka ng mga amino acids na yan, tataas din yung methylmalonyl-CoA mo. Okay? And the presentation will be seizures, as I've said, seizure, stroke in the young. Biro mo, 1 month to 1 year. No? How do we treat? Again, dietary restriction. So avoid proteins, especially these amino acids. We give L-carnitine and cobalamin supplementation. So dietary modification is important to restrict these amino acids. So, ano yung pwede nalang itanong? Which amino acid should be restricted in methylmalonic acidemia? So, hanapin mo yung MVIT. MSUD, maple syrup urine disease. No? So, this is a deficiency in alpha-keto acid dehydrogenase complex, which metabolizes your branched-chain amino acids. Ang tanong lamang naman dito, what are the branched-chain amino acids? The branched-chain amino acids are isoleucine, valine, and leucine. So, ang deficient yung pangalawang enzyme, your alpha-keto acid dehydrogenases. No? Tataas ngayon ito, yung alpha-keto acids. So, si isoleucine nagiging alpha-keto isovalerate. Si valine nagiging alpha-keto methylvalerate. Si leucine nagiging alpha-keto isocaproate. Ang pinaka-culprit dyan, yung si leucine. No? So, especially alpha-keto isocaproate accumulation. Now, in Harper, take note, the enzyme is keto acid decarboxylase. No? The enzyme is keto acid decarboxylase. So, sometimes you might see that in the choices instead of keto acid dehydrogenase. So, because of the accumulation of keto acids, no, they will have a characteristic odor in the urine. Actually, not just urine, but all body secretions. Yung buhok nila, yung totoli nila, no? Amoy maple syrup. So, treatment. So, dietary restriction. So, they have this special milk formula, which is restricted yung valine, leucine, and isoleucine. If you start treatment early, they can have normal development. No? So, histidinemia. The problem with histidinemia, there's defective histidase, which converts histidine to urocanate. Tataas ngayon yung histidine levels. No? So, it's considered benign. No? So, previously associated with intellectual disability, but it's considered benign. So, just be familiar with this table, no? So, again, ang important dito, you need to know the amino acid involved. Anong pinaka-common sa kanila? Pinaka-common will be phenylketonuria. So, you see this, no? Incidence is around 8 per 100,000 live births. So, problem, you cannot convert phenylalanine to tyrosine. Albinism, anong problem? Tyrosine pa din yan. No? Tyrosine pa din yan. Here, dito yung mga urea cycle disorders. So, remember, kung ano yung nag-accumulate, no? Malalaman mo ngayon ano yung enzyme deficiency. Okay? Kapag sinabing methionine pathway, methionine to cysteine, anong iisipin? Homocystinuria. No? So, methionine degradation. So, just be familiar with this table. So finally, we discuss heme metabolism. No? So what is heme? First, we discuss what porphyrins are. So porphyrins are cyclic compounds formed by the linkage of 4 pyrrole rings through methine bridges. So important na malaman nyo ano yung porphyrin because your porphyrins will be the building blocks of heme. So where do you find the porphyrin ring? So here, when you look here, this is a porphyrin ring, this is chlorophyll, and this is hemoglobin. So you will see in chlorophyll, at the center of the porphyrin ring is magnesium. In contrast, in hemoglobin, in heme, which is found in hemoglobin and myoglobin, at the center will be iron, in its ferrous form, Fe2. Heme synthesis is important because heme is present in almost all tissues. So I know you're more familiar with hemoglobin and myoglobin, but hindi lang doon merong heme. So for example, your cytochromes. In the electron transport chain, if you remember, you have your cytochrome. And then in drug metabolism, cytochrome P450. Enzymes, catalase, peroxidase, guanylate, cyclase, they all contain heme. So heme synthesis is present in almost all tissues, just like cholesterol. So where does heme synthesis happen? Cytosol? Mitochondria? The correct answer, of course, is both. Diba? HUG, H-U-G. Heme synthesis, urea cycle, gluconeogenesis. It begins in the mitochondria. It goes out into the cytosol. And then it goes back to the mitochondria. So yun yung unique sa kanya. So yung heme synthesis, mitochondria, tas lalabas, tapos mitochondria ulit. So the first step, you will see here, happens in the mitochondria is the conjugation of glycine, amino acid, with succinyl-CoA, which is part of your Krebs cycle. So glycine with succinyl-CoA combine to form delta-aminolevulinic acid. So or delta-amylolevulinate. So glycine plus succinyl-CoA, ALA. This requires pyridoxine or vitamin B6. This is also the rate-limiting step. Now look what happens, no? So from here, so synthesis, ito yung mga steps, no? Synthesis of ALA. After we synthesize ALA, we now form porphobilinogen or PBG. Okay? PBG is yung combination niya ng magko-combine yung dalawang ALA molecules. Okay? And then we form uroporphyrinogen, which is actually the first, no? Yan yung first porphyrin, yung meron na tayong porphyrin ring. So here na, so ALA, tapos PBG, but the porphyrin ring, you only see it in uroporphyrinogen. Now from uroporphyrinogen, you have a series of steps of decarboxylation and oxidation. Eventually, you form protoporphyrin 9. And then protoporphyrin 9, you add iron to form heme. So again, once again, ALA will combine to form PBG. From PBG, you form uroporphyrinogen, which is the first porphyrin ring. And then you incorporate iron as Fe2 into protoporphyrin 9 using the enzyme ferrochelatase. The important thing here is ferrochelatase and ALA dehydratase. These are susceptible to inhibition by lead. No? These are susceptible to inhibition by lead. Vitamin C, bakit important yung vitamin C? Vitamin C is important because it helps you increase iron absorption. And then ceruloplasmin is involved in the oxidation of iron, no? Para ma-oxidize siya, para yung oxidized form niya Fe2. So clinical correlates. So sa clinical correlates natin, lead poisoning, this is lead paint. So wala na nito, no? So you must remember that there are two enzymes that are susceptible to lead inhibition. Si ALA dehydratase, which is step number 2, and ferrochelatase, which adds iron, incorporates iron into the porphyrin ring. So what will happen? If you have lead poisoning, syempre tataas yung ALA. No? Kasi nga hindi siya maka-move down sa pathway. You'll have anemia, microcytic hypochromic anemia. You have peripheral neuropathy. You have deposition of lead. So this is lead. Look at lead in the epiphyseal plates. You have lead in the gums. No? And then, acutely, you can have nausea, abdominal pain, and diarrhea. So, dati, no, yung mga bata, kinakain. Tinanggal na yung lead sa paint. Kasi yung mga bata, no, tinutuklap nila yung pintura, tapos kinakain nila yung pintura. Now, this one is more important, your porphyrias. Now, to be honest, I haven't seen a single patient with porphyria. This is not something we usually think of when you think of patient. No? Diagnosis is often delayed in these patients because the symptoms are very non-specific. Tatandaan nyo lang, if you have disorders in heme synthesis, may enzyme deficiencies sa heme synthesis, ang manifestation nun, porphyria. In the same manner, if you have defects in urea synthesis, the manifestation will be hyperammonemia. So ito naman, no, basta heme synthesis disorder, porphyria yung sagot. No? They can be classified as either erythropoietic or hepatic depending on whether which organ is more involved, yung bone marrow ba o yung liver. Now, the clinical presentation, this is interesting. No? Yung porphyria, if you remember, sabi natin, no, yung heme synthesis, initially ALA, tas PBG. And then you form the porphyrin ring, yung uroporphyrinogen. Kapag yung block natin, no, pag na-block yung pathway before the formation of the porphyrin ring, so ang mag-accumulate lang doon, ALA and PBG, the manifestations will be mainly neuropsychiatric. So, neuropsychiatric yung symptoms, behavioral changes, erratic behavior. Sometimes they're mistakenly diagnosed to have psychiatric illnesses. But if the block occurs after the formation of the porphyrin ring, meaning to say, nag-accumulate yung porphyrin rings, then you get photosensitivity. So why? You get photosensitivity because the porphyrinogens are oxidized to porphyrins. And these porphyrins lead these photosensitizing molecules lead to the formation of superoxide radicals. And your superoxide radicals, of course, destroy your tissues, leading to inflammatory responses. So once again, no, so this is the porphyrin pathway. No, this is the heme synthesis, no, glycine plus oxydyl-CoA, porphobilinogen, and you will see hydroxymethylbilane you can already form your porphyrin ring. So pag ang block natin nandito sa taas, no? Pag ang block mo nandiyan sa taas, no? So ang mag-accumulate yung porphobilinogen, ALA, no? Ang presentation neuropsychiatric. Pero pag ang block natin nandito, no? From hydroxymethylbilane going down, no? Hydroxymethylbilane going down, no? Then you already have, no? Then you already have your photosensitivity. So look here. Ito yung blistering associated with porphyrias. Okay, so this is a summary, no? So this is a summary now. You will see, look, acute intermittent porphyria, neurologic lang yung manifestations, no? So neurologic lang yung manifestations. Walang, no, photosensitivity. No, walang photosensitivity because if you look, acute intermittent porphyria, ALA and PBG lang yung mag-accumulate sa kanya. So the most common presentation is acute severe abdominal pain. The urine can be dark or reddish. No, there's change in color in urine because of the pigments, and you will see confusion, hallucination, and seizures. So you see here. So if you go back to this table, acute intermittent porphyria, porphobilinogen deaminase. So ito pa lang yung mag-accumulate, no? Porphobilinogen, aminolevulinic acid. So the urine usually changes in color on exposure to light and air. Okay. Variegate porphyria, chronic blistering naman, no? Similar to porphyria cutanea tarda. So porphyria cutanea tarda, this is the one that's most common. No? So porphyria cutanea tarda, what happens is that most commonly, no, ito yung blistering disorder siya. It is the only one that's related to it is the only one that is related to iron. No? So you can have normal or elevated iron levels. Okay, it is also most readily treated. So how do we treat this? No? So we usually just treat them by giving hydroxychloroquine. Hydroxychloroquine removes the excess porphyrins from the liver. Erythropoietic porphyria, this is the third most common and most common in children. So this time, no, the accumulating naman, no, ang mag-accumulate dito, protoporphyrin. Again, dahil meron na tayong porphyrin ring, pag erythropoietic porphyria, no, meron ka ng photosensitivity. Usually, the symptoms subside within 12 to 24 hours. Now, more than the porphyrias, this is actually what you need to understand better, no? Yung heme degradation, kasi ito yung mas may encounter natin during the clinics, no? You have patients who present with jaundice. Okay, so how do we degrade heme? So remember, your red blood cells only have a life cycle of 120 days. After 120 days, what happens? So this one, you have your red blood cells, they are degraded in the reticuloendothelial system. So, di ba, in the liver, in the spleen, you degrade the red blood cells that are aged. Okay, so after 120 days, no, mafi-filter out yung the old red blood cells. What happens? The iron will be recycled. Look here, yung iron i-recycle natin yan. Yung heme, i-metabolize naman natin, no? So, take note, no, lagi nila itong tinatanong, this is the only pathway in the body that produces carbon monoxide. Pag tinanong kayo, no, what pathway produces carbon monoxide in the body? The correct answer is heme degradation. So, what happens to heme? No? So, yung hemes from the red blood cell, tanggalin mo yung iron, recycle. Yung heme will undergo metabolism. Why? Heme is very non-polar. Kailangan natin siyang ma-excrete. So, kailangan natin siyang gawing polar. So first, we convert heme to biliverdin. And then biliverdin is converted to bilirubin. So yung biliverdin, color green. Yung bilirubin, color red-orange. So, di ba pag nagkapasa kayo, di ba? Pag nagkaroon kayo ng pasa, anong unang kulay? Reddish-purple because of the acute blood. After a few days, it becomes greenish. And then it becomes light brown, red-orange. That reflects the change from heme to biliverdin and then to bilirubin. Now, what are the enzymes? Heme to biliverdin, that's heme oxygenase. As I've said, heme oxygenase releases carbon dioxide and ferric iron. And then biliverdin undergoes reduction, biliverdin reductase to form bilirubin. So heme oxygenase to biliverdin, no? To bilirubin using biliverdin reductase. Bakit ito important, no? So these are performed by the heme oxygenase system of the reticuloendothelial cells. What happens to bilirubin? Bilirubin is non-polar. Ayaw niya sa tubig. No? Ayaw niya sa water. But remember, it's in the liver and the spleen. Kailangan mo siya excrete. So paano siya ngayon magta-travel sa blood? Bilirubin will bind to albumin. So bilirubin will bind to albumin. So this becomes a problem. Why? So for example, if you take drugs that excessively bind albumin, i-displace nila si bilirubin. Kaya pwede kang magka-hyperbilirubinemia. No? Pwede kang magka-hyperbilirubinemia. So now, yung bilirubin, nakasakay siya kay albumin, saan siya pupunta? Pupunta siya kay liver. In the liver, bakit siya dadalhin sa liver? Because in the liver, you will conjugate it. You will add 2 molecules of glucuronic acid. Yun yung tinatawag natin ng conjugation. When you add 2 molecules of glucuronic acid to bilirubin, it becomes bilirubin diglucuronide. Okay? Bilirubin diglucuronide. Bilirubin plus 2 molecules of glucuronic acid. Saan natin pinoduce yung glucuronic acid? Glucuronic acid comes from what molecule? Glucose. Diba? Uronic acid pathway. Glucose can be oxidized to glucuronic acid. So, anong purpose nun? Diba? Si bilirubin non-polar siya. Pag kinabitan mo kasi siya ng glucuronic acid is acidic. It becomes more polar. So, terminology, focus here. This one, bilirubin, is what we call indirect or unconjugated bilirubin, which is non-polar. Pag meron ng nakakabit na glucuronic acid, it becomes polar, conjugated, direct bilirubin. No? At dahil polar na siya, pwede na siyang i-secrete sa bile. Okay? So what happens if you do not have bilirubin glucuronyl transferase? No? Kung wala tayong enzyme na to, that's what happens in Crigler-Najjar. In Crigler-Najjar syndrome, you do not have this enzyme. So, anong tataas? Unconjugated or conjugated? Unconjugated or indirect hyperbilirubin. Bilirubin. So, it leads to unconjugated indirect hyperbilirubinemia. Do you understand? Okay, so yung bilirubin diglucuronide, sisecrete na ngayon siya sa bile. Okay, so bilirubin is transported into the bile canaliculi, then into bile. No? So what happens kung merong gallstones, mababarhan yung bile. What happens next? So you will see here, ito, no? So unconjugated, sa liver i-conjugate, pag conjugated na, pupunta na siya sa intestines. In the intestines, the bilirubin is converted to urobilinogen. Yung urobilinogen pupunta sa kidney where it's converted to urobilin. Pag bilinogen, pag bilinogen, always remember may color, no? Pag bilinogen, may color. Okay, kapag bilin, pag bilin, wala. Okay, that's why pag bilinogen, walang color, no? So pag urobilinogen, walang color. That's why you see here, no, urobilinogen, wala siyang color. Pero sa kidney, mako-convert siya to urobilin, which is yellow. That's why our urine is yellow. No? That's why our urine is yellow. Now, yung urobilinogen in the intestines, it is converted to stercobilin, which is brown. Kaya naman, no? So, kaya yung stool naman natin, brown. Let's analyze. What if, for example, you have biliary atresia? So, in biliary atresia, hindi nag-develop yung biliary tree. So, if you do not develop biliary tree, what will happen? Yung bile, hindi siya makakarating sa intestines, correct? So, yung bilirubin, hindi siya makakarating sa intestine. Yung bilirubin diglucuronide. Kaya ano mangyayari sa stool nila? Walang stercobilin. Kaya yung chalk white yung stool. Okay? Kung meron naman tayong obstructive jaundice, no, may gallstone dito sa common bile duct, what happens? Ano kaya ang tataas? Indirect or direct bilirubin? So, direct. No? Tataas na ngayon yun. Kasi yung sinisecrete natin sa bile duct, conjugated bilirubin na yan. No? Conjugated bilirubin naman yan. Okay? Paano kung masyadong maraming hemolysis? Kunyari, meron siyang sickle cell disease. Hemolyze yung red blood cells niya. Anong tataas? Dahil yung tumataas, yung increased degradation of red blood cells, hemolytic anemia, ang tataas, unconjugated. Kasi ibig sabihin, ma-overwhelm yung liver, hindi niya ma-conjugate lahat. That leads to indirect hyperbilirubinemia. Yun yung kailangan nyong i-memorize. You need to know which will present with indirect hyperbilirubinemia and which one will present with direct hyperbilirubinemia. This clinically manifests as jaundice. No? So, yung Van der Berg reaction, yun yung ginagamit to say, no, kaya siya naging direct bilirubin, indirect bilirubin. Kasing Van der Berg reaction, ang minimeasure lang niya direct, no? Direct bilirubin. Tapos yung direct bilirubin sinusubtract sa total bilirubin. Kaya ang tawag dun sa unconjugated indirect kasi it's indirectly computed from the level of the direct bilirubin. Okay? So this table is very important, no? So you will see here from blood, no, bilirubin is bound to albumin. It's transported to the liver where it's conjugated. Pag yung block natin nandito, then it's indirect hyperbilirubinemia. Okay? Or, so, gaya sabi ko kanina, hemolytic anemias, physiologic jaundice, Crigler-Najjar, walang enzyme. Okay? Direct hyperbilirubinemia, kapag nasekrete mo na siya, pero yun naman yung tataas. So, biliary tree obstruction, Dubin-Johnson, and Rotor syndrome. So, ang problem sa Crigler-Najjar, there's no bilirubin glucuronide transferase activity, lalo na sa type 1. So, this is really incompatible with life pag hindi mo to na-treat. No? So, shortly after birth, they have very high levels of bilirubin. No? You have bilirubin encephalopathy and rapid death. Sa type 2, reduce lang yung activity. So, total bilirubin, less than 20. Ang mataas, indirect bilirubin. So, compared with type 1, no, meron pa tayong nako-conjugate maski pa paano. So, generally, good prognosis. Okay. So, what about your conjugated hyperbilirubinemias? So, yung conjugated hyperbilirubinemias, yung conjugated hyperbilirubinemia is yung Dubin-Johnson tsaka yung Rotor syndrome, no? So you will see, so important to. So if you compare yung Gilbert syndrome, no, it is also a type of unconjugated hyperbilirubinemia. Okay? Yung Dubin-Johnson tsaka yung Rotor, no? So Rotor is a Filipino, Arturo Rotor, no? So si Dubin-Johnson tsaka si Rotor, conjugated hyperbilirubinemia, no? So ang distinguishing features, si Dubin-Johnson, take note, black liver. Lysosomal pigment on histology, pigmented yung liver niya. Si Rotor, ang distinguishing feature naman niya, conjugated siya, no? Conjugated siya and then elevated corproporphyrin. No? Elevated corproporphyrin. But all of them have benign, okay? All of them are benign and have normal liver enzymes. So all of these are autosomal recessive. They are all benign. No? Sa hyperbilirubinemia, tandaan lang kapag Gilbert unconjugated, just like Kriller-Najjar, Dubin-Johnson and Rotor, paano mo sila madidistinguish? Sa Dubin-Johnson, may pigmentation ng liver. Sa Rotor, elevated corproporphyrin. So in summary, so amino acidopathies result from deficiencies in enzymes that metabolize amino acids. So remember, you just need to identify what amino acid is involved, what enzyme is involved. Most of the time, the treatment is restriction of the offending amino acid, so dietary restriction of proteins. And then you supplement the deficient nutrients. So for example, for phenylketonuria, you give tyrosine. For homocystinuria, you give cysteine. Heme synthesis is present in all tissues because almost all tissues use heme. So if you have a deficiency in heme synthesis, that leads to porphyrias. No? The clinical presentation, it depends on whether porphyrins have accumulated or not. So pag meron ng formation ng porphyrin ring, then you get photosensitivity. Pero pag ang meron pa lang ALA and PBG, which is early on in the pathway, so such as in acute intermittent porphyria, then you only have neuropsychiatric symptoms. Heme is metabolized to bilirubin. So remember the pathway, heme to biliverdin to bilirubin. And then bilirubin, you have to add 2 molecules of glucuronic acid to form bilirubin diglucuronide. Depending on the pathophysiology, hyperbilirubinemia may be conjugated or unconjugated. So please remember, try to memorize what will be unconjugated or indirect, non-polar hyperbilirubinemia, and what will be direct, conjugated, polar hyperbilirubinemia. So I forgot to mention, between the two, direct and indirect hyperbilirubinemia, which one will lead to kernicterus? The answer, of course, is indirect hyperbilirubinemia. Kasi why? Yung indirect, di ba, yun yung non-polar? Because it's non-polar bilirubin, it is the one that will cross the blood-brain barrier. And because it crosses the blood-brain barrier, it will deposit in your brain, especially sa basal ganglia. You know what the basal ganglia is for? It's for refinement of movement. That's why yung mga to, yung mga patients, pag lumaki sila, they will have abnormal movement disorders. Yun yung nagiging clinical manifestation.